extend a very warm welcome to all our esteemed doctors and participants. Thank you all for joining us today on this scientific session on management of malignant tumors in lung and liver cancer. Now, let me very quickly welcome our very first speaker, Dr. Pranay, consultant medical oncologist at Omega Hospital, to talk for their session. Over to you, sir. Please kindly share your slides. Dr. Pranay. Dr. Pranay, can you hear us?
Hello.
Yes. Good evening, Dr. Pranay.
Yeah, good evening.
Yes, sir. Please go ahead. You can start your session. You can kindly share your slides, sir.
Right. I'm sharing.
Yes, sir.
So, am I good to share?
Yes, sir. Please go ahead.
Sir, can we share your slides?
One second. It's not allowing me. What happened?
So do you want us to share a screen?
I've made some changes actually.
Okay, sir.
Give me, please, give me 2 minutes. Browser is preventing access. Or can I share you my slides? Hello. Am I
Yes,
audible?
sir. Yes. Yes, sir. You are audible. You can share your slide. Now, please share screen.
Are we there?
Yes, sir.
Hello. Hello.
Yes,
Sir,
sir. You are audible. Now, can you please share screen?
Hello. Mute chat.
इतना नहीं बोलना, बस चुप हो जाओ, कर लेगा वो। यस, ग्रुप में कुछ नहीं, नथिंग।
Hello.
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 Yes,
Hello.
Dr. Pranay, you are audible and you shared screen. You can
Yeah.
start your session.
Yeah. I'm sorry. I mailed you the my slides. Can you please share them from your side?
Okay, sir. Sure.
I've just mailed you.
Okay, sir. Sir, on which email ID you have shared that slides?
Shagun.sharma.
Okay, sir. Just a second.
Shagun.sharma at HCMPL.
Okay. So just give us a minute. We are sharing it.
Yeah. Yeah. Please. Thank you. Hello.
Yes, sir. Please, you can start your session.
Yeah. Very good evening, everyone. And first of all, very sorry. Absolutely, I'm extremely sorry for delaying this. There was a little glitch on my this thing. So yeah, without wasting much time, today I'll be discussing about the management of unresectable HCC. Next slide. Yeah. So when you look at the incidence of HCC, uh, globally it stands seventh among the most common cause of cancer, and also it's fourth most common cause of cancer related death globally. Next slide. So, and unfortunately, up, up to 45% of the patients are diagnosed in locally advanced stage, or those who are those in metastatic setting, those who are already metastatic, and the prognosis for these patients is very poor. Uh, Next slide. So in India, it's the 11th most common cancer and also 8th common cause of cancer-related deaths, and with a slight male preponderance at the at 4:1 ratio, and the median age at diagnosis is 40 to 70 years, and the incidence increases in cirrhotic at 1.6% per year. Next slide. And there is so looking at the risk factor, there are multiple risk factors for the development of hepatocellular carcinoma, ranging from the viral etiology, that is the chronic hepatitis B or C infection, or with the substance abuse like alcohol, tobacco, or aflatoxin, and the metabolic causes like non-alcoholic fatty liver disease, and non-obesity or diabetes, and other factors like autoimmune hepatitis. So all these factors contribute to the state of chronic inflammation leading to cirrhosis and ultimately landing up with HCC. And recently, earlier it was the viral etiology that has been the most common cause for HCC, development of HCC. Now recently, the non-alcoholic fatty liver disease has taken first step, which causing more number of causing increased risk for HCC. Next slide. Yeah. So this is the overview of the BCLC staging which we commonly do for hepatocellular carcinoma. Uh, quickly going, BCLC for stage 0, that is early stage, very early stage and early stage. The treatment options are either either resection or liver transplantation based on eligibility criteria. And for intermediate stage, it is TACE with or without systemic therapy. And for advanced stage, it's always a systemic therapy. And for terminal stage, that is stage D, it's always the best supportive care. Next slide. So today in our discussion, we'll focus about the advanced stage HCC, that is BCLCC, where the systemic therapy options include the first line regimes like the approved as on date, the atezolizumab plus bevacizumab, or durvalumab plus tremelimab, called the stride regime. And the second line options include regorafenib, cabozantinib, uh, cyramza, and and third line options are cabozantinib. Next slide. So we look at the now we look at the management of advanced or unresectable HCC using immunotherapy plus a VEGF inhibitor. Next slide, please. So this is a quick overview of the phase 3 trials that have been done and the approved drugs for the management of HCC. For advanced stage, the earlier drug which was approved was sorafenib based on the SHARP trial, which was compared with the placebo, and then came lenvatinib based on the REFLECT trial that compared with sorafenib, and both of these trials had only a modest improvement in overall survival. So there was a still unmet clear need for the improvement in overall survival. So there came the first trial the tried immunotherapy was IMBRE 150, where they have given atezolizumab plus bevacizumab compared with the sorafenib, which was then the standard of care while starting this trial. And other noteworthy trials later include the Himalaya trial, that is a stride regime, and the checkpoint 9DW, which included double in Nivo plus EP. These are the two trials which so which tried dual immunotherapy combinations. Next slide, please. Next slide, please. Yeah, so looking at the AMBRAVE study, so it's a phase 3 multicentric open label trial which included local advanced or metastatic unresectable HCC with in patients with reasonably good PS, that is 0 or 1, and and with a well reserved hepatic function, that is childbirth class A, and and the patients were randomized in 2:1 ratio to atezolizumab at 1200 milligram plus bevacizumab 15 milligram per kg, sorry, 15 mg per kg given every 3 weekly versus sorafenib 400 milligram BD. So both of the treatments were continued until disease progression or unacceptable treatment toxicity. And the trial and the patients were stratified based on the region, that is the Asia versus rest of the world, and the macrovascular inflammation whether present or not, or whether or not extra hepatic spread there, and the baseline AFP being less than 400 versus more than 400. And the co-primary endpoints of this trial were overall survival and the progression-free survival as assessed by independent review facility. And the secondary endpoints included overall response rate, safety, and safety. Next slide, please. Yeah. So the baseline characteristics were well balanced between the in the both arms. The median age was 64 to 66%, 66 years, and the majority of the patients included were in good PS with the with the well preserved hepatic function, that is Child-Pugh class A, and also the majority of the most of the patients were BCLC stage C. And this trial the both arms in the both arms included were across all etiologies, that is a viral and non-viral, and majority of the patients in the both arms were had extra hepatic spread of the disease or with a macrovascular invasion. Next slide, please. Yeah. So, and approximately 21% of the patients in this AMBER study included patients with high risk features, that is VP4 stage, that is involvement of the main portal vein trunk, or with a tumor at least more than 50% of the involved liver, and or with the bile duct invasion. Next slide, please. So, looking at the updated analysis, the overall survivor with Atezo plus Bev was significantly higher compared to sorafenib. When we see the curve started to separate early as 2 months, and they remained separated throughout, with an absolute delta of more than 10% between the Atezo plus Bev versus sorafenib, with an absolute gain in median OS of nearly 6 months compared to sorafenib, and the hazard ratio being 0.66, there was 34% in reduction of death. So when we see the OS is maintained, the overall survival benefit is at least more than 10% across at 6 months or 12 months or 18 months. Next slide, please. Also, there was significant improved PFS of 4.3 months with sorafenib versus 6.9 months with Atezo plus Bev, with a 6 months PFS rate of 38% versus 55, and 12 months PFS 21% versus 35%. Next slide, please. Yeah, and the overall response rate were also better with Atezo plus Bev compared to sorafenib. At least more than 50% of the patient had a stable disease or higher, that is partial response or complete response rates, and only 19% of the patient had progression of disease. And the median duration of response were also higher in Atezo plus Bev arm, that is 18.1 months versus 14.9 months. Next slide, please. Yeah, so and the OS benefit was maintained across all subgroups, those with Asia and the rest of the world, or in irrespective of the PS and the BCLC stage C, whether AFPF even in AFPF more than 400 at baseline, or and also in those with patients with extra hepatic spread or macrovascular invasion, and even in high risk patient, except for one subgroup, that is a non-viral etiology HCC, the overall survival curve slightly crossing unity, favoring sorafenib. Next slide, please. But in the post-hoc analysis of etiology and outcomes, the tumor response rate were similar across all etiologies, that is alcoholic liver disease or viral related CC, or non-alcoholic fatty liver disease. So the post-hoc analysis shows there was no significant difference in proportion of patients who had response across all etiologies. Next slide, please. So when you look at the Kaplan-Meier curves of PFS and OS, the curves are almost closely overlapping with each other, irrespective of etiology, that is alcoholic or non-alcoholic or viral etiology, and the hazard ratios are always of all the three subgroups compared with each other are close to unity. So, in spite of the earlier notion that Atezo plus Bev fares usually better in viral etiology HCC, uh, in spite of this, the authors concluded that the the benefit was seen even in non-viral etiology, and while considering treatment for with Atezo plus Bev, etiology should not be considered while considering Atezo plus Bev as a treatment of choice. Next slide, please. and the median PFS was also better with atezolizumab plus bev, irrespective of etiology, that is 5.6 months. Though there is a little a bit magnitude of benefit is little higher with viral etiology. The benefit is is seen across all etiologies comparing with sorafenib. Next slide, please. And the tumor response rate in AMRE 150 were also deeper compared with sorafenib. At least 74, that is 74% of the patient had at least partial response rate, and only fewer patients had disease progression, only 19% in the atezo plus bev arm. Next slide, please. And even in patients those who had stable disease had reasonable overall OS data, and the progression, though we cannot do a cross trial comparison, the progression of the progressive disease rate, that is 19%, are relatively much lower compared to other IO trials, though the cross trial comparison needs to be done with caution. Next slide, please. The duration of response is also much longer with atezolizumab plus bev compared to sorafenib, with which we can see as a with the long tail at the end. Next slide, please. So those with patient comparing with the extent of portal vein invasion, that is VP4, so that is graded as main portal invasion versus non VP4. So the benefit is seen across even in patients both VP4 and non VP4 in terms of median OS, median PFS, or overall response rate, or even grade 3 4 treatment related adverse effects were also less with atezolizumab plus bev compared to sorafenib. Next slide, please.
So, Dr. Pranay, so sorry to interrupt. Can I request you to please conclude your presentation as we are short of time?
Right, yeah. Last to say. So,
Okay, sir.
so esophageal varices is something which we are worried about was starting bevacizumab, and in this trial there was nearly 26% of the patients who had esophageal varices, and there was no and the benefit is seen even in patients with those varices. Next slide, please. Yeah, and the esophageal varicose bleeding was only less. The majority of the bleeding occurred through epistaxis only. It was nearly 10.3%. Next slide, please. Coming to safety, so there was no new safety signals. The atezolizumab plus bev arm, the common related adverse effects were hypertension, proteinuria, and with sorafenib it was hypertension, hand-foot reaction, and diarrhea. And the time to deterioration of quality of life was also significantly longer with atezolizumab plus bev, that is 11.2 months, with just 3.6 months with sorafenib. Next. So atezolizumab plus bev satisfies all the three factors in terms of higher response rate, deeper and longer response rate, and also not only the patient lived longer, they also lived better with atezolizumab plus bev in terms of quality of life. Next, please. Next slide, please. So yeah, the treatment goals for in advanced stage include the prolongation of overall survival by adding multiple lines of therapy. All this can be possible while maintaining the adequate liver function. Next slide, please. So these are real world data on how well the liver is preserved after starting an atezolizumab plus bev. So that is more than 70% of the patients were able to were eligible for second line, and a study from Korea shows 66% were able to take second line, and from Japan it is 88%, nearly 88% patient had undergone second line therapy with preserved liver function. Next slide, please. So to conclude, atezolizumab plus bev continue to demonstrate a clinically meaningful results in terms of median OS, PFS, and response rate, and also it remained consistently higher across all subgroups, even in viral and non-viral etiology, and also it is pretty much safe to be delivered in patients with varices or with major portal invasion, that is VP4. Thank you.
Thank you so much, sir. Thank you so much
Thank
for
you.
the insightful presentation. I would like to invite Dr. Vindya Vasudha, Senior Consultant Medical Oncologist at Omega Hospital. Over to you, ma'am. Kindly share your screen.
Thank you for the kind introduction. Without much delay, I will be starting my presentation, which would be more like an extension of Dr. Pranay's. So, I would be talking about the real world data, how the trial results have actually reflected or improved the real world data. So, this is the chief real world cohort, which is the French cohort. So, these are the disclaimers. So, we have seen from the previous speaker's presentation that as per the IM-Brave 150, Tisobev has become the global approved number one treatment, first line treatment in HCC, unresectable HCC, and it has shown superiority in all the three significant gold standard endpoints, that is overall survival, PFS, and the response rates. When we see at the overall survival, the largest Atizo-Bev combination, that is the IM-Brave 150 trial, showed the largest OS delta as compared to the other trials, that is the Himalaya and the Checkmate, though this is a cross trial comparison, but this is the best we have. Moreover, patients with poor prognostic factors like the VP4 were included in the IM-Brave trial, IM-Brave 150, whereas they were excluded from the other two trials. So, in spite of having more high risk population, there is an improvement, better performance of the Atizo-Bev combination compared to the other two trials. Thus, it became the practice changing combination or trial where Atizo-Bev has become the first line treatment for the advanced hepatocellular carcinoma, though there is a limited follow-up data of less than 3 years. So, this can be valued or reiterated by our confidence can be reinforced by similar results, if not better results from the real world data. So, real world data may complement the RCTs by evaluating different treatments in a broader population. So, the randomized trial data is usually present in the tightly controlled populations, but the real world data can confirm whether the RCT results are observed in everyday clinical practice, provide complementary insights from more varied settings, and help to translate these RCT findings into high quality evidence that can guide routine clinical practice. In effect, the real world data shows high insight on the clinical practice, and it has superior access to the relevant healthcare data. Therefore, real world evidence are important to inform treatment decision making, as they are more representative of our routine clinical care and supports a wide variety of clinical decisions where evidence from large clinical trials is scarce, and it supports regulatory approval, and the complexity, that is potential limitations based on confounding and bias possibilities, are always there with the real world data, and there is a need for extrapolation and adaptation, not pervasive. So, when we look at the efficacy and safety findings from the four key real world data studies, there are these four real world data studies: the De Castro, AB Real, Rimini, Ramaswamy et al., and the Chief trial. So, all of them, they reflect the IM Brave results, both in terms of median overall survival, progression free survival, response rates, and also in the adverse event profile. Now let us look at the real world study, that is Chief Hepatolong study, which was a French cohort. This is the extended follow-up at 42 months of Atizo-Bev in advanced HCC. So this Chief cohort, the French study, was done in around 33 French centers after IM-Brave 150 results were declared, and Atizo-Bev had become the first line of choice, and they recruited patients across various French centers from 2020 to 2025, and all patients were treated with Atizo-Bev. Patients with childhood C and D were excluded, and overall survival and PFS were assessed. Objective response rates was defined as the presence of either a complete or a partial response. So this is the flow chart. Around 4,500 patients data was extracted, of which 894 patients received Atizo-Bev in the first line, and around 880 patients data was analyzed. When we look at the patient characteristics, majority were male, with alcohol being the most common underlying liver disease. Child PUG A was 78%, and majority were BCLC C. Vascular invasion was seen in around 47% of the patients. So when we look at the extended follow-up at 42 months, the overall survival was at 42 months was 44%, with a median overall survival of 22.8 months, which reflects, if not better, it was better than the IMBRAVE trial where it was around 19 months. And when we look at the various predictive factors of mortality, presence of esophageal varices, ascites, and an ALB score grade of 2 were adverse prognostic factors or predictive factors of mortality. When we look at the overall survival according to the Child-Pugh score, obviously patients with Child-Pugh A fared better than Child-Pugh B, with a median overall survival of 27.4 months versus 9.8 months for Child-Pugh B. And patients with BCLC B had better overall survival compared to BCLC C. Median overall survival of 27.8 months for B compared to 18.5 months for C, with a significant p-value. And when we look at overall survival according to the ALB grade 1 fared better than grade 2 or grade 3, which was highly significant. The median OS was not reached for ALB grade 1, whereas it was 15.9 months for grade 2, grade 3. When we look at the OS according to the vascular invasion, patients with no vascular invasion fared better than patients with vascular invasion. Almost doubling of the median median overall survival was seen in patients who had no vascular invasion. And when we look at the progression-free survival, here again the progression-free survival median PFS was 5.8 months, and predictive factors for progression were again the Child-Pugh score, the neutrophil lymphocyte ratio, presence of BCLC-C, and AFP greater than 400. And again similar PFS data was seen as per the Child-Pugh grading and BCLC stage. Patients with better Child-Pugh score and lower BCLC stage had better median PFS compared to higher grade. And when we look at the best responses, almost 50% had stable disease as the best response, 28% had objective response. And overall survival according to the best response, patients who had some objective response had better overall survival, which was not reached. The median overall survival was not reached, whereas patients with stable disease, the median overall survival was around 30 months, and patients with progressive disease had less than around 12 months of median overall survival. So when we look at the long-term data, 44% of patients were still surviving at 3.5 years of follow-up. So our long-term real-world data shows that nearly 1 in 2 patients are still alive at 3 and 3.5 years. And the median overall survival was 23 months as per this chief cohort. So this study confirms the results observed in the pivotal trial. Here the median overall survival was 22.8 months, whereas it was 19.2 months in the IMBRAVE 150 trial. Around 880 patients were analyzed, a significant number of patients who received Etizobev as first line. They were monitored and analyzed in this real world cohort. So in conclusion, the overall survival rates at 42 months showed an unprecedented overall survival in the real world practice, which reinforces the long-term durable benefit of the Etizobev combination in advanced HCC. So with this I come to the end of my presentation. So the gist of this presentation is that the trial results were well reflected in the real world studies, most of the studies, and in this particular study which I have presented, it has even surpassed the expectations, thereby reinforcing our confidence in this combination as first line treatment for unresectable HCC. With this, I now hand over the session to the organizers.
Thank you. Thank you so much, Dr. Now, I'd like to invite our next esteemed speakers, Dr. Shaini Reddy, consultant medical oncologist at Omega Hospital, for his session. Over to you.
Thank you, Ma. So, first of all, I like to thank Roche for the opportunity to speak today. Good evening, everyone. Can you please present the slides?
Sure, ma'am.
So basically, over the next 20 minutes, I will be discussing about one of the landmark trials that has changed management of resected non-small cell lung cancer, which is nothing but the IM Power 010 trial. So this is the first positive phase 3 study which demonstrated that adjuvant PD-L1 inhibition after surgery and chemo, it has significantly improved the disease-free survival. We will be looking into the details in the subsequent slides. Next slide, please. So these are my disclaimers. Next slide, please. So this slide, it highlights one of the biggest challenges we face in the lung cancer management. We know that surgery offers the best possibility for cure, but again, complete surgical resection is just not equivalent to cure. We have seen large number of pooled analysis, especially the latest meta-analysis and numerous observational studies, which demonstrated that recurrence is very common despite surgery. For patients with stage 2, they have approximately 60% chance of recurrence, whereas for stage 3 patients, almost 3 out of every 4 patients, they eventually relapse. This is even after receiving the adjuvant platinum chemotherapy. So, and the relapses are most often systemic also. So here comes the role of any additional therapies. This is where immunotherapy was tried. And also at this point of recurrence, the quality of life is also a major issue. Many of the patients showed that there is significant anxiety which surrounds the relapse. And it is one of the major concerns for patients after curative surgery. So if we look at the survival curves on the right, we can see that even among patients who underwent complete resections, survival, it decreases progressively with the increasing pathological stage. If we look at the 5-year overall survival for stage 3A, it's just approximately 50%. So just surgery, even with combined with chemotherapy, is not completely enough for cure for most of the lung cancer patients. Next slide, please. So why do these recurrences occur even after curable surgery? It is mostly due to the micrometastatic disease. So these are the tumor deposits which are too small to be identified by our routine imaging, may it be CT or PET CT. So there are numerous studies which have been done over the last 2 decades. They consistently demonstrated that the presence of micrometastasis in the lymph nodes, it was associated with significantly worse outcomes. If we look at the figure on the right, we can understand the biological pathway of recurrence. Basically, the tumor cells from the primary lung cancer, they can disseminate during the very early in the natural course of the disease. We have seen similar course in the breast cancer patients also. So the tumor cells, they migrate to the lymph nodes. From there, some of the cells may be circulating as circulating tumor cells. Then they gain access to the systemic circulation, they enter the bloodstream and they get deposited in various organs. This is all not visible on the conventional imaging. So the goal of any adjuvant chemotherapy is to address this micrometastatic disease. So as we all know, the LACE meta-analysis, it demonstrated that by giving adjuvant platinum-based chemotherapy, it improved the 5-year overall survival almost by 5%. So this is the first proof that there is a micrometastatic disease and patients benefit by administration of adjuvant therapy, may it be chemotherapy or immunotherapy. Next slide, please. So basically, let's look at the mechanism of action for the adjuvant chemoimmunotherapy. What is the role actually? So as I told, after the curative intent surgery, many of the patients will have some amount of micrometastatic disease. So the adjuvant immunotherapy, it is administered after surgery and after the completion of adjuvant chemotherapy. The sequence is very important because the surgery removes the majority of the tumor burden, and then chemotherapy, it further reduces whatever residual tumor burden is there. It induces the cell death. It releases the tumor antigens. So these antigens, they are presented to the T lymphocytes in the regional lymph nodes. However, we know that the tumor cells, they develop various mechanisms to evade the immune destruction. And one of the most important pathways to evade the immune destruction is by the PD-1, PD-L1 interaction, We all know that atezolizumab is a monoclonal antibody which is directed against PD-L1. So basically, by blocking the PD-L1, this atezolizumab, it prevents the inhibitory signaling through the PD-1 pathway. Thereby, the immune system, whatever is suppressed, the exhausted T cells, they become reactivated. And in this way, the goal of the immunotherapy post-surgery and post-chemo, we are looking not just at disease control, we are looking at cure. Next slide, please. So looking at the trial per se, the IMpower 010, it's a global multi-center randomized phase 3 study. This was basically done to determine whether adjuvant atezolizumab following the platinum-based chemotherapy, whether it could improve outcomes in patients with completely resected early stage NSCLC. So most of the patients, they had stage 1B to 3A NSCLC, and this was according to the AJCC 7th edition staging system, because the study was done at that point of time. And here, stage 1B patients, they were included only if the primary tumor was at least 4 centimeters. Of course, patients had to have a good performance status and surgical resection had to be done. And tumor tissue must be available for PD-L1 testing. We will see why. And every patient, they should receive the standard platinum-based adjuvant chemotherapy. And only patients who have completed this adjuvant chemotherapy, they were randomized in a 1:1 ratio. So one arm received atezolizumab 1200 mg once in every 3 weeks, total of 16 cycles, and the other arm received best supportive care. The randomization, it was also stratified according to the gender, the disease stage, the histology, and the PD-L1 expression status. The primary endpoint of this study was the disease-free survival. However, the statistical analysis, it was performed during a hierarchical testing in 3 specific predefined populations, which I will be discussing in the next slides. The key secondary endpoints of this trial were the overall survival. So this is the hierarchical testing model, which I have been talking about in the previous slide. So it actually, the trial, it tested the primary endpoint in the predefined population. So the main concept is that only if the significance is achieved in one population, then only the testing could proceed to the next population. So the first population which was tested was patients with stage 2A and 3A disease, wherein the PD-L1 expression must be at least 1% of the tumor cells. So this is essentially the biologically enriched population. So if there was statistical significance was met in this population, then only the study could proceed to the second, third, and the subsequent steps. Next slide, please. So when we look at the baseline characteristics of the patients, almost 1,005 patients were randomized after completion of the chemotherapy. 38% of the patients were more than 65 years of age. Majority were male, as we all know, and some 3/4 of the patients were white and 1/4 of the patients were Asian patients. This is important here because we know that EGFR mutations are more prevalent in the Asian populations. Of course, majority of the patients had a good performance status, and the study included both squamous and non-squamous histology patients. And 12% had stage 1B disease, 30% had stage 2A, and 17% had stage 2B disease. And 78% of the patients were current or former smokers. Also, we need to note that 55% of the tumors, they demonstrated PD-L1 expression of at least 1%. And this was done using the SP263 assay. And there was very well-balanced distribution of the PD-L1 positive patients between both the treatment arms. Next slide, please. So first, we will be looking into the efficacy analysis of the first subset of the patient population. That is, we will be looking at the DFS in the PD-L1 stage 2, stage 3A patients where the PD-L1 is more than 1%. Next slide, please. So approximately 248 patients received atezolizumab here in this arm, and 228 patients received best supportive care. So when we look at the Kaplan-Meier curves, here the blue curve represents the patients treated with adjuvant atezolizumab, and the red curve, patients undergoing observation alone. So we can see from the curve that during the first few months, the curves are relatively close together. Then as we follow, the separation between the curves is increasingly apparent and the curves continue to diverge over time. And this sustained separation is one of the key things which we see in most of the immunotherapy trials. So if we look at 24-month data, the disease-free survival approximately 74% with atezolizumab and 61% in the observation arm. And at later time points also, this benefit is very durable. And if you look at 3 years, the DFS approximately 60% with atezolizumab and 48% with observation. If we look at the median disease-free survival in the atezolizumab arm, the median disease-free survival is not reached here. That means that more than half of the patients in the immuno arm, they remain disease-free at the time of analysis. And the median DFS in the observation arm was 35.3 months, hazard ratio of 0.66, very significant p-value of 0.004. Since this study met its primary endpoint, the investigators went on to look at the second subsequent testing. Next slide, please. So this slide represents a subgroup analysis. Here we can see that almost all the patients had benefit with atezolizumab irrespective of the age, gender, race, performance status, and smoking history. But we can see clearly that the magnitude of benefit, it was greater in patients with stage 3A disease, those who had node-positive disease, and those with a non-squamous histology. And we can also see that some subgroups with the EGFR mutations and ALK mutations, they did not show a clear benefit. Next slide, please. So we will be now looking into the DFS in the second subpopulation, that is stage 2, stage 3A patients, wherein all the patients who are randomized irrespective of the PD-L1 status. Next slide, please. Here also we can see a good separation of the Kaplan-Meier curves. And at 24 months, the disease-free survival rate was 70% with atezolizumab and 61.5% observation. And the median disease-free survival in the atezolizumab arm was 42.3 months, and in the observation arm it was 35.3 months. So hazard ratio of 0.79, p-value of 0.02, which is significant. Hence, the testing proceeded to the next step. Next slide, please. So looking at the subgroup analysis, here also majority of the patients observed benefit as the histological subtype, but what we can make out clearly is that there was a very clear relationship between the benefit and the PD-L1 expression. Next slide, please. So here in this slide, we can clearly see that the benefit of adjuvant atezolizumab, it is strongly influenced by the PD-L1 expression levels. So already in the PD-L1 positive population, that is a tumor cell more than 1%, atezolizumab reduced the risk of recurrence or death by 34%. Hazard ratio here is 0.66. And this benefit is much more pronounced in those with the PD-L1 expression more than or equal to 50%, where the hazard ratio is 0.43. For patients with intermediate PD-L1 expression, that is 1% to 49%, hazard ratio of 0.87. And PD-L1 negative patients, the less than 1%, hazard ratio of 0.97. We can clearly see that PD-L1 expression is a key predictive marker for selecting most patients who will benefit from the adjuvant atezolizumab. Next slide, please. So subsequently, we will be looking into in the entire intention to treat population, that is the stage 1B and the stage 1B to the stage 3A patients. Next slide, please. So here, when we look at the Kaplan-Meier curves, we can see that there is separation favoring of atezolizumab, but we can clearly make out that the magnitude of separation here is much smaller when compared to the previous two studies. Here, the median disease-free survival was not reached at the time of analysis. The median DFS in the observation arm, it was 37 months. Hazard ratio of 0.81. A p-value of 0.04, and this study did not formally meet the predefined statistical significance boundary. This could be because patients with stage 1B, they typically relapse later than those with other stages of the disease, and this may explain why DFS did not cross the significance boundary in the entire intention to treat population at this point of analysis. Next slide, please. Coming to the overall survival, there were 5 formal OS time points where the analysis was planned in the intention to treat population. Next slide, please. So this slide shows the first interim overall survival analysis. This is in the predefined PD-L1 positive stage 2, stage 3A population. This is a primary efficacy population. This is done approximately almost after 4 years of follow-up. Looking at the Kaplan-Meier curves, that the atezolizumab curve remains consistently above the observation curve. Here, the overall survival rate at 3 years, 82% with atezolizumab, 78% with observation. And if we are looking at the deaths, 52 deaths in the atezolizumab arm compared with 64 deaths in the observation arm. Median overall survival not reached in either of the treatment arms, in neither the atezolizumab nor the observation arm. Hazard ratio for overall survival 0.71. But the confidence interval, we have to note that it is crossing 1 here. Next slide, please. So in this slide, we are looking at overall survival in 2 different populations. One is the all randomized stage 2, stage 3A population on the left, and the overall intention to treat population, that is stage 1B to 3A disease on the right. So if we are looking at the left curve, almost similar number of deaths in both with treatment groups. Hazard ratio 0.95, not statistically significant. If we are looking at the right side of the curve also, almost a similar number of deaths in both the treatment arms, hazard ratio of 0.9, not significant here too. Next slide, please. So let's look at the biomarker status, overall survival based on the biomarker status. So which patients actually derived survival benefit from adjuvant atezolizumab? If we first look at the forest plots on the left-hand side of the slide, upper panel, it includes all patients, including those which have EGFR and ALK mutations, and the lower panel excludes these mutation patients. So if we are looking at PD-L1 expression of at least PD-L1 expression of at least 1%, hazard ratio for overall survival 0.71. And PD-L1 expression of at least 50%, hazard ratio much better, 0.43. And PD-L1 negative tumors, hazard ratio was actually 1.36. And lower panel also, excluding EGFR and ALK alterations, if we look at the different hazards for different PD-L1 expressions, we can very well make out that the patients who derived maximum benefit was those with higher PD-L1 expression levels. Next slide, please. So this is an ASCO 2024 update, wherein the left panel shows the disease-free survival. Here we can see that there were 34 DFS events in the atezolizumab arm and 55 events in the observation arm. And even after 5 years of follow-up, there is a substantial reduction in the recurrence events in patients who received the atezolizumab. So the DFS hazard ratio 0.49 and a very good DFS rates at landmark points. So on the right panel shows the overall survival. Here also, overall survival hazard ratio was 0.44, corresponding to almost 56% reduction in the risk of death, and a very good landmark overall survival rates at 3 years and 5 years. Next slide, please. So this is an ESMO 2024 poster analysis where it represents updated 5-year characterization of the long-term disease-free survivals from the IMpower 010 study. So left panel, we can see that the investigators, they evaluated patients with stage 2, stage 3A, PD-L1 more than 50%, who remained disease-free at 5 years following treatment. So here we can see that almost among all the demographic and the clinical subgroups, a higher proportion of the patients receiving atezolizumab, they remained disease-free at 5 years when compared to patients who received best supportive care. So this benefit was seen irrespective of the age, sex, the performance status, the duration of the adjuvant immunotherapy. And what we have to note here is that there was sustained benefit in stage 3A disease, where 60% of the atezolizumab treated patients remained disease-free at 5 years when compared to only 30% in the control arm. So the right panel, it shows the biological factors which are associated with the long-term disease-free survival. Here we can see that the greatest separation, it was observed in patients with high tumor mutation burden, supporting that the concept that more immunogenic tumors, they derive greater benefit from the checkpoint inhibition. Also, we can also note that patients with negative circulating tumor DNA status after treatment, they achieved favorable outcomes. So achieving a negative circulating tumor DNA level is very important for long-term good survivals. Next slide, please. So let's look at some of the main safety analysis. Next slide, please. So before looking at the safety analysis, we need to see how many of the patients received the planned therapy and what was the distribution. Here we can see that a median of 10.4 months of atezolizumab therapy was administered, and almost 100% dose was administered in most of the patients, and majority of the patients completed almost 16 cycles of the atezolizumab treatment. Next slide, please. So if we look at the overall safety profile, we can see that there are no new safety signals. Adverse events were slightly more frequent with atezolizumab when compared with the best supportive care patients. All grade adverse events 90%, and 3 to 4 grade adverse events in 20% of the patients. And severe immune-related toxicities were relatively uncommon. Grade 3 to 4 adverse events or adverse events of special interest in 7% of the patients. Next slide, please. So if you look at the grade 5 adverse events, they were quite uncommon, occurred only in 1.6% of the patients receiving atezolizumab when compared to 0.6% in the control arm. Also, treatment-related grade 5 immune events were also very rare, occurred only in 0.8% of the patients. Next slide, please.
Excuse me, ma'am. Sorry to interrupt, but
Yeah.
I request you to please
Yeah,
complete
just the
your
last
question.
2 slides. Yes.
Yeah,
Yes.
sure.
So if we are looking at adverse events of special interest, many of them like rash, thyroid dysfunction, hepatitis, they were all low grade and manageable. Next slide, please. So other adverse events like diabetes, myositis, and other pancreatitis and all were relatively uncommon. There were no new safety signals. Next slide, please. So with this, we come to the conclusions. Yeah, so as I already told, this is the first phase 3 study wherein immunotherapy was tried in the adjuvant setting. So as we can see that adjuvant atezolizumab following complete resection and adjuvant chemotherapy, it showed a statistically significant DFS benefit, especially in the PD-L1 more than or equal to 1% stage 2 to 3 patients, and also in all randomized stage 2 to 3A patients. And majority of the patients who derived clinical benefit had higher PD-L1 expression levels. So DFS in the entire intention to treat population, when we included stage 1B, it did not cross the significance boundary. Next slide, please. OS trend in favor of the atezolizumab, it was seen in the PD-L1 more than 1% stage 2, 3A population at the time of the first specified interim analysis, and the safety profile, no new safety signals. So the conclusion is that atezolizumab may be considered as a practice-changing adjuvant treatment, especially for those with PD-L1 more than or equal to 1%, stage 2 to stage 3A NSCLC. Thank you for patient hearing.
Thank you so much. Thank you so much, Dr. Shiny, for this amazing session. Now I'd like to invite Dr. Pallavi S. Ladda, consultant medical oncologist at Baswat Karm Indo-American Cancer Hospital and Resource Center for their session. Over to you, ma'am.
Good evening, everybody. Can you see my slides?
Yes, ma'am.
I think everyone. I think you can hear me and my slides also visible now.
Yes,
Yes,
ma'am, we
ma'am.
can hear you.
Yeah.
Ma'am,
So
please make it full screen.
today we are discussing about extensive stage small cell lung cancer. So already we discussed about the stage 3 lung cancer also, non-small cell. Now this is small cell lung cancer. So this is I'll discuss about the I am power 133 and I am Brella A study also, which is an extension of this I am power 133 study. So the in small cell lung cancer, we know from last 20 years we are giving only chemotherapy, which is like carboplatin and etoposide, which is last 20 years we are giving same therapy. So with this extensive stage small cell will initially respond to chemotherapy, but then typically they will progress within 11 or 12 months of the therapy. And 5-year survival rate of this is 2% and median overall survival is only 10 months. So there is the goal of this combination with immunotherapy is to create a more favorable environment to maximize the potential of the immune system to eliminate the cancer. So that's how the old treatment of our carboitopo has been upgraded and added in that immunotherapy also actually. So we can see the 5-year overall survival rate is very poor with extensive stage small cell lung cancer when we treated with chemotherapy alone. So stage 4 5-year survival rate is only 2% with the chemotherapy alone. So now this IM power 133, what they did is they added immunotherapy atezolizumab plus chemotherapy. Chemotherapy arm is same like carboplatin and etoposide, and in placebo also the same carboplatin etoposide be given. So in this they took patient population is ECOG performance score 0 1, no prior systemic treatment, and patient treated with asymptomatic brain mets also was eligible for this patient for this study. And the randomization is 1:1 placebo versus chemotherapy and immunotherapy. And the maintenance the after 6 cycles of 4 cycles of carboitopo, the maintenance atezolizumab has continued and discontinued till the progression. So here the primary endpoints was overall survival and PFS, whereas secondary endpoints were objective response rate and duration of response and safety profile. So we can see here what is our this OS. We can see here first the curves had not separated, but slowly the curves had been separated and they diverge further. We can see here 12 months the OS is in placebo arm 38%, whereas 51.7% in the treatment arm. So more than half of the patient with atezolizumab and chemotherapy were still alive at 1 year. And in IMBRAVE 133 met its co-primary endpoint, that is improved OS, and this is the first OS benefit we can see in last 20 years in the extensive stage small cell lung cancer. And we can see the hazard ratio of this is 0.70 with significant p-value of 0.0069 and OS of 12.3 in the treatment arm. So there is a reduction in the risk of death in 30% in which is really clinically meaningful in especially aggressive disease like this. So now coming to the PFS, OS also in the median follow up around 22.9 months, we can see there is a demonstrable median OS versus in the treatment arm versus the placebo arm, and with hazard ratio of 0.76. So which is really benefited for the patient. And progression free survival, we can see there that IM power 133 also met its progression free survival. We can see at 6 months progression free survival is 30.9 versus 22.4 months in the placebo arm. And this at 12 months and beyond, definitely 12.6% is the PFS. And here hazard ratio is 0.77 with significant p value 0.017. So there is a meaningful even progression free survival is there with this atezolizumab and chemotherapy arm. And now coming to the side effects profile, we can see here the both the arms, the chemotherapy treatment is same, like 4 doses of carboplatin and 12 doses of etoposide. And but we can see here the treatment related grade 3 and grade 4 adverse event in the treatment arm, like chemoimmunotherapy arm is 67.6%, whereas placebo arm in chemotherapy it is only 63.3%. So there is not much difference in the side effects profile. And treatment related serious adverse events is 38.9% in the immunochemotherapy arm, whereas if 35% in the placebo arm. Then the treatment which is required to withdrawal of the treatment or the stoppage of the treatment required in 11.6%, whereas in placebo it is 2.6%. So IM power 133 is a positive trial of an immunotherapy and chemotherapy in combination in first line therapy of a extensive stage small cell lung cancer, and the first major treatment advance in the last 20 years, which shows a really clinically meaningful improvement in OS. And we can see here even NCC and ESMO, they also recommend the first line treatment with the atezolizumab and carboplatin and etoposide in an extensive stage small cell lung cancer. The superior survival benefit demonstrated in IM power 133, that is median overall survival of 12.3 months versus placebo of 10.3 months, and patient alive at 1 year in 52% with AT and chemotherapy arm, whereas 38% in carboitopo arm. So the another next landmark trial is 6 years survival benefit. This is the extension of IM power 133, that is umbrella 8 extension study, which shows the first immunotherapy combination with 6 years survival data in a patient with the extensive stage small cell lung cancer. So here we can see once the clinical cutoff the date has been finished with the IM power, then the remaining patient has shifted to only maintenance atezolizumab. They roll over and they that is a extension study, that is IM umbrella A extension study. These patients which are were eligible, they continue to receive the immunotherapy at the study closure, and they again followed up actually. So the patient number is only 18, but then we can see here at 6 years also the patient has performance score of 1 in 66% in the I umbrella, and even the patient included were even brain mets and liver mets. So they continued and atezolizumab, and then we can see here the 5-year survival rate is OS 5-year is 12%. So we can see in extension study of this at atezolizumab, 12% were survived till 5 years also. So 5 year survival in small cell lung cancer itself is a very much useful, and then definitely the side effects profile also not very different from the chemotherapy arm in this. So we can see here the 6 year survival OS data is also there. So 6 years, 11% of the patients 11 patient survive, and they have reached having a meaningful overall survival. So this safety outcome we can see here, because some patients continued on same therapy, and we should see the safety outcome, whether they stop the treatment because of the drug or not, we should see. So we can see here the safety, actually only side effects which are only in the 27%. And I think we need more patient population to continue and get the safety profile better in this population. So overall survival data rate in the across all the small cell lung cancer, we can see other immunotherapies like durvalumab also we can use, and pembrolizumab we can use. But see the keynote 604, the 3 year survival rate is 16%, whereas in the durvalumab arm it is around 18%, whereas in the I am power 130, it is 16%, and the even 6 year survival rate is OS survival rate is around 11%. So finally, we can see here it is an extended study of IM power 133, IM umbrella A, and definitely it has a meaningful overall survival. And we can see at 6 years or so, 11% patients surviving and doing well. So this is a really a good on is immunotherapy, and there are very less treatment options in the small cell lung cancer actually. So I think we should advise the atezolizumab with chemotherapy and see the this good overall survival in our patients. Thank you very much.
Thank you so much, Dr. Pallavi. Now I'd like to invite Dr. Harshvardhan Anadhanam, Consultant Medical Oncologist at Omega Hospital. Over to you, sir. Kindly share your screen, please.
Good evening, everyone. Can I share this slide? Good evening. Today I'm talking about sorry, I'm not able to scroll the slides. So, hello, I'm not able to share the slides.
Okay, sir, we will share the screen.
Okay. Thank you. Good evening, everyone. Today I'm talking about atezolizumab monotherapy in first-line metastatic non-small cell lung cancer. This is a disclaimer. So I'm basically talking about IM power 110. So it is basically atezolizumab compared to chemotherapy in PD-L1 selected first-line non-small cell lung cancer patient. So the inclusion criteria were stage 4 non-squamous or squamous NSCLC, that is both adeno and squamous are included. Chemotherapy naive, PD-L1 selected population, EGFR ALK negative, and stratification factors for the sex, ECOG, PS, histology, and PD-L1 HC expression. That PD-L1 testing was done on Ventana SP142 ICSA. Their hierarchical testing was done. If they see the benefit in the PD-L1 high population, then they won't do the testing in the lesser PD-L1 population. That is IC3 or TC3 population were tested basically. That is randomized to atezolizumab compared to chemotherapy in non-squamous, that is pemetrexed plus carbo or cisplatin. In squamous, gem with carbars cisplatin, and for adeno population, pemetrexed maintenance was continued. For squamous, best supportive care. In atezolizumab group, atezolizumab maintenance given until progressive disease. Primary endpoint was overall survival, and the key secondary endpoints were PFS, overall response rate, and duration of response. And the baseline characteristics were comparable between the groups. Age or sex differentiation or racial differentiation or the tobacco essays, ECOG-PS, all are balanced between the two groups. Coming to the primary endpoint, overall survival, by adding atezolizumab, improved overall survival of 12 months OS of around 64% compared to 50% in the chemotherapy arm. That is, median OS was around 20 months compared to 13.1 months, with the absolute OS difference of 7.1 months with the atezolizumab compared to chemotherapy, with a hazard ratio of 0.59, which is statistically significant. The similar trend is seen with the progression-free survival in the high PD-L1 population. That is, median PFS was around 8.2 months compared to 5 months with the chemotherapy, with a hazard ratio of 0.59, which is statistically significant. You can see the curves are separated. And coming to the overall response rate in PD-L1 high population with atezolizumab, it was 40% compared to 28%, which is definitely better than the chemotherapy. Coming to the, if we across different PD-L1 testing platforms, that is SP142 or DACO22C3 or SP263, in all three platforms also, atezolizumab showed a significant overall survival benefit compared to chemotherapy. There might be minor differences, but across all platforms, there was a significant benefit with atezolizumab. So we can use the different platforms while using the atezolizumab monotherapy. Coming to the safety profile, when compared to chemotherapy, as expected, atezolizumab was well tolerated, and the adverse events grade 3 or grade 4 were lesser when compared to chemotherapy. And the common side effect, as all we know, more frequent with chemo, that is all bone marrow suppression is more common with chemotherapy, and the same way immune-related side effects like hypothyroidism, rash, and all more common with the atezolizumab. So, on summarizing, IMpower 110 is a positive study that demonstrated statistically significant and clinically meaningful improvement in the overall survival in PD-L1 high population versus platinum-based chemotherapy. It also showed a meaningful improvement in PFS, overall response rate, and duration of response compared to chemotherapy. The safety profile of atezolizumab was consistent with prior observation. No new unexpected safety signals were identified. Thank you.
Thank you so much, Dr. Hamid. I'd like to invite Dr. Rekha Bansal, consultant at Apollo Hospital, for her insightful session. Ma'am, kindly share your screen.
So I hope you can see my slides.
Yes, ma'am.
Awesome. So I, I'll try to be brief because this is a simple topic that has been given to me. So I'm going to talk about the patients that no one talks about. So we are going to look at the role of Tecentriq in first-line patients with advanced NSCLC who are unable to take a platinum. So we all know for a long time, and even now for all the patients of metastatic NSCLC, in first line, we prefer a platinum-based chemotherapy doublet along with immunotherapy whenever indicated. But if the patient is not able to take a platinum, then what do we do? So just to very quickly, lung cancer is the fourth most common cancer in India. And most of the cancer-related deaths are also happening due to lung cancer. 85% of the lung cancers are NSCLC, and most of these patients, unfortunately, even to this day, come to us in stage 3 or 4. Now, all is fine as long as the patient is fitting into the trial criteria, but not all patients fit into the trial criteria. As this slide says, in the real world setting, more than 40% of the patients diagnosed with lung cancer have a performance status of more 2 or more, and they have substantial comorbidities. And more often than not, or in fact, most of the times, these patients are excluded from the immunotherapy trials. Although we know that these patients have poorer survival when compared to patients who have preserved performance status, that does not mean they don't deserve a chance. Unfortunately, they are because they're not included in the clinical trials. We don't know what is the right way to treat these patients. Also, not only the comorbidities, it's also the age. So most of the trials they stop recruitment at 65 years of age. Whereas we do see patients who get diagnosed above this age. So these patients come under the contraindication to use platinum based doublet chemotherapy. And I'm sure most of us see these patients in our clinical practice. So how do we decide the treatment of a patient when a stage 4 patient who does not have a targetable genetic mutation comes to our OPD? Of course, histology matters, PDL1 expression matters. We are going to talk about those patients who have PDL1 expression less than 50%, and who have, for various reasons, uh, who for various reasons are ineligible for receiving a platinum-based doublet. So it is never one factor; it is a multitude of factors. Obviously, with increasing age, comorbidities increase, and there are sometimes something as basic as social issues, familial issues. So all of these contribute, and we have to, the onus lies on the physicians to make a judgment call and try to give the best to the patient. So according to the guidelines, what do we do in these patients who are coming to us in performance status 2 or more than 2? Then, of course, we will try to give them platinum based, that is carboplatin based therapy, or else we might opt for a single agent chemotherapy. But there is no data for monotherapy immune checkpoint inhibitor in this patient population because none of these patients were included in the trials. And I will show you what data exists for other immune checkpoint inhibitors. What about the elderly population? Again, like I said, more than 65, most often they are excluded. So even though a patient who's chronologically more than, patient could be even 75, but they could have adequate PS and adequate organ function. So in these patients, again, we try to give a platinum doublet, more often carboplatin based. And wherever not possible, we switch to single agent. So this Moon OSS trial, this looked at what patients do receive whenever they are not eligible to receive platinum. Then in that case, they end up getting either single agent chemotherapy, like 25% of the patients, or sometimes they get a platinum combo, which is carboplatin based. And more often, the cause for calling them ineligible is older age, comorbidities, lower performance status, or family issues. So there is a set criteria to say when patient is not eligible for cisplatin, when patient is not eligible for carboplatin, or even the single agent chemotherapy. I'll quickly walk you through this. So cisplatin, as we know, it has renal toxicity. It cannot be given for a heart failure patient, and it cannot be given for patient who already has neuropathy or hearing loss. So that constitute the eligibility criteria for cisplatin. Now, when it comes to carboplatin, it is little more liberal. There is no cutoff as such, but we are able to use it even for elderly patients, even 80 and above. And performance status, even sometimes 2 and above, we have given carboplatin. There is no absolute restriction of, creatinine clearance like for cisplatin, but still we are very vigilant whenever the creatinine clearance is less than 45. And of course, a frank heart failure patient, we would not be able to give. Barring that, there are no other criteria that we have to look for carboplatin. So carboplatin is a little bit more liberal when, we can use, of course, not like stringent like cisplatin. So what is the data for single agent use of chemotherapy whenever we are not able to use even the carboplatin based doublet? What is the data? We have gemcitabine based data. Most of this is phase 2 data. Most of it is from Europe. Small uh, patient populations, as you can see. Of course, docetaxel data is quite big, and it's a phase 3 data. More often, so each of these studies, they have used different criteria, more or less similar criteria, to call them platinum ineligible. And then you can see what were the median OS which were rendered with each of this agent. So gemcitabine gave a median OS as a single agent of 9.8 months in this patient population, whereas vinorelbine has given 7 months, docetaxel 5 months, and pemetrexed 4.7 months. So is there any data at all of single agent NSCLC in these frail patients? So there is data, but none of it is positive. There is no first line data of pembrolizumab in this poor performance or platinum ineligible patients. There is PEPS2, which is pembrolizumab in performance status 2, but this was a single arm phase 2 data, small trial, only 60 patients, and median OS was 7.9 months in first line, PFS was 4.3 months. Nivo EP, they showed that it is detrimental. Durvalumab was also detrimental. So then we talk of Ipsos study. This study is a phase 3 global multicentral open label randomized study. Indian patients representation was also there. This basically looked at atezolizumab versus single agent chemotherapy in this patients which are poor performance and who are not eligible for the first line platinum based chemotherapy. This is more or less what we had discussed. So either histologies, performance status 2 or 3 were allowed. And of course, they were mutation negative. Treated asymptomatic brain metastases were allowed. Stratification factors were histology, PDL1 expression, which was looked at by SP142, and brain metastasis was also a stratification factor. So they were randomized in 2:1 to receive either single agent atezolizumab in the standard dose 1200 every Q3 weekly versus chemotherapy, which could be vinorelbine or gemcitabine, until disease progression. There were secondary endpoints. Primary endpoint was OS. Secondary endpoints were OS at 6 months, 12, 18, and 24 months, PFS, objective response rate, duration of response, and to look at the effect of the PDL1 expression. So if you see, most of the patients, about 40% patients belong to 70 to 79, and about 30 patients were above 80 years of age. And most of the patients were in the performance status of 2, ECOG performance status 2. There was good representation of Asians. Most of the patients were non-squamous, and 70% patients had smoking history. 9% patients had brain metastasis. PDL1 expression, if you see, only about 15% of patients or 17% of patients had more than 50%, TC more than 50%, and 75% patients had less than 50. In that, again, if you see the subdivision, 50% patients had less than 1% of PDL1 expression. So let us see how PDL1 expression affected the responses, of course, eventually. So the primary endpoint was met. It was a positive trial. There was improvement in the overall survival when single agent atezolizumab was compared with the use of single agent chemotherapy, hazard ratio of 0.78. And the benefit was seen across the different subgroups. And I would just bring to your notice, regardless of the amount of the PDL1 expression, the benefit was seen. Again, the PFS endpoint was also met. And if you see the overall response rates, I think this is more interesting. There is almost doubling of the overall response rates, and there is durable response. The duration of response was also doubled. So this gives hope to this set of patients which are generally excluded from the trial. So again, this giving atezolizumab did not affect their quality of life. In fact, if anything, there was improvement, whereas chemotherapy did show deterioration of the quality of life across different domains. So when you look at the function scales, role function, social function, cognitive function, everywhere there was deterioration of function. Again, if we see the other quality of life analysis, EORTC, QLQ-C30, and QLQ-LC13 symptoms wise. So symptoms wise, when you see cough, peripheral neuropathy, insomnia, chest pain, alopecia, appetite loss, I think everywhere uniformly, chemotherapy caused the deterioration of quality of life. This shows again the forest plot here shows that atezolizumab fared better when compared to chemotherapy if you look at the quality of life. Now, coming to safety, of course, we know chemotherapy would have caused all grade toxicity was higher with chemotherapy, more grade 3, grade 4 AEs with serious AEs were, uh, I mean, I think they were comparable, depends on how you define AE. But of course, there were no new safety signals identified with atezolizumab per se. We know the immune related adverse event and adverse event of special interest, which we generally see with immunotherapy, and we know how to manage them. Sometimes they require use of corticosteroids. So as you can see, only 11% patients required use of corticosteroids, and only 6% patients had grade 3 AEs of special interest. Rest of them were of grade 1 and 2 only. So there is hope for these patients who belong to poor performance status, who are more than 70 years of age, who have poor renal function or multiple comorbidities. This is incorporated in the guidelines also, NCCN, ESMO, and the local guidelines. So to conclude, the single agent atezolizumab, when compared to single agent chemotherapy in patients who are poor performance status or ineligible to receive a platinum-based doublet chemotherapy, atezolizumab showed improvement in the overall survival. Benefit was seen across subgroups. There is doubling of the OS. There is doubling of the overall response rate. And this happened without affecting the quality of life. No new safety signals were identified. Thank you.
Thank you so much, Dr. Rekha, for your insightful session. Now I'd like to invite Dr. Esther Frizzi, consultant medical oncologist at Omega Hospital. Over to you, ma'am. Kindly share your screen also.
Thank you, Roche, for giving me this opportunity to speak about uh, pioneering innovation in non-small cell lung cancer with subcutaneous immunotherapy. So we all know that apart from IV immunotherapy, we have options of subcutaneous immunotherapy. Among these molecules, we have atezolizumab, pembrolizumab, and nivolumab, all in the subcutaneous form. But today, I would like to highlight the Tecentriq molecule in subcutaneous formulation because it was the first um, subcutaneous formulation that was available worldwide. So let's take you through the slides. I am unable to just, yeah. Yeah, as I said, the introduction, mainly my topic of discussion would be subcutaneous formulations in immunotherapy, and that too Tecentriq molecule. So the data for we all know that IV formulation, and we are very familiar with IV formulations. But today my topic is actually stressing upon the subcutaneous because subcutaneous is upcoming and it was recently approved. So that's why we need to put in more light with respect to subcutaneous molecule. So the data for subcutaneous comes from two trials. One is the immunotherapy subcutaneous injection 001 trial and the 002 trial. So these two trials are the basis for our the subcutaneous formulations. So I will go through these two trials in detail in the upcoming slides. So let me take you through the timeline. So the data on 001 was successfully published or presented in ESMO-IO December 2022, and so on and so forth. In 2023 in August it was presented in ESMO again, and it was launched in UK in the month of August, and followed by the EMA approval, that is the European Medical Association approved this subcutaneous formulation in January 2024. And that's about the EMA approval. And after that, in March, in European Lung Cancer Congress, so 002 trial study was published. And later, the FDA approved this formulation in September. And in India, the DCGI approved it August 2025. So as I said, the atezolizumab or Tecentriq was the first subcutaneous checkpoint inhibitor, which was approved worldwide, and now it's also available and approved in India. So, as I said, the 001 trial deals with the pharmacokinetics of Tecentriq subcutaneous formulation. So, why they made it? It's a groundbreaking breakthrough. Why? Because we all know that the IV formulation we are familiar, but the subcutaneous formulation, they came up with a molecule such that it is easier to administer within a very short duration of time, and all that is possible because of this enzyme called human hyaluronidase enzyme that is developed by the Holozyme Therapeutics. It has a very short half-life, and it is transient and reversible. I will tell you why it is important. So this atezolizumab molecule is combined with this hyaluronidase enzyme. Tem enzyme. So when we inject the subcutaneous formulation, what actually happens in the skin or the dermis, the dermis and the subcutaneous tissue have a lot of hyaluronic acid. So when we give this injection, so what this hyaluronidase enzyme does is it degrades the HA, that is hyaluronic acid, at the injection site with no changes in the structure, providing macromolecules. So what happens is the temporary degradation of the hyaluronic acid makes it more permeable for the drug to seep into the subcutaneous tissue, and enabling administration of larger volume of the drug. So this vial comes in 15 ml. So we are able to give 15 ml subcutaneously easily because of this hyaluronidase combination. So after the subcutaneous administration, the architecture of the skin is reformed within 1 to 2 days with no damage, and due to the rapid clearance of this enzyme, and there is a production of HA again. So that's why this effect is very temporary. It does not damage the skin, and it's easy to administer. So coming to the 001 trial per se. So it was done in two parts. The part one was a 1B dose finding study, and the part two was a phase 3 randomized non-inferiority study. So basically, we want to prove that subcutaneous formulation was non-inferior to IV formulation. So here what they have done is they had randomized non-small cell lung cancer patients, that is from stage 3B to 4, who are immunotherapy naive and who had failed or progressed on first line platinum based chemotherapy with ECOG status 0 and 1. So they had randomized in the ratio 2:1. Here the Tecentriq subcutaneous dose was 1875 milligram fixed dose every 3 weekly, which was given, and versus Tecentriq IV formulation 1200 milligram, which is also given 3 weekly. So when we come to, because these are pharmacokinetic randomized studies, so we need to know something called as trough levels and AUC levels. So the primary endpoint of this phase 3 trial was to know the concentration trough level at the end of the cycle 1 and the AUC levels. And also the secondary endpoints were to know the safety, efficacy in terms of overall response rates, overall survival, and also to know the immunogenicity. So the PK parameters are important for understanding the bioequivalence between IV formulation and subcutaneous formulation. So here there are 3 parameters that are important for us to know. That is, one is the concentration trough levels, and the other is the AUC levels, and the third one would be the Cmax levels. So for us, the Cmax does not play a very important role, whereas these two, the trough levels and the AUC levels, are very important. Um, so, this uh, graph speaks about when we give IV formulation. So immediately what happens is the plasma levels of the atezolizumab peak, and then slowly the peak it reaches a peak, and slowly again it starts falling downwards. But whereas in subcutaneous, when we give subcutaneous administration, what happens? The drug is concentrated in the subcutaneous plane, and slowly it gets released into the bloodstream. So what we have here is the drug concentration slowly increases in the bloodstream, reaches a max, and then again it falls back. So what I mean to say from from this graph is the Cmax for the IV and the subcutaneous is different. But just because it's different doesn't mean that our sole parameters or the efficacy depends upon Cmax. It is not. So we need to look at something called as a trough level. So the trough levels is nothing but the lowest concentration of the drug in the blood immediately before the next scheduled dose. So we draw the blood of the patient on day 21 of the first cycle and check for the atezolizumab levels in the blood. And the AUC, as we all know, is how much of the total drug exposure did the patient receive throughout the cycle. That is from 0 to 21, how much of the drug has been exposed. And the Cmax is nothing but the peak concentration. So, but for us, the Cmax does not play, as I said, the Cmax does not play an important role because the efficacy of the drug depends upon the sustained target engagement and not on achieving a very high concentration. Why? Because the PD-1 and the PD-L1 receptor occupancy is maintained even at low concentrations of the drug in the bloodstream. Okay, so that I would like to highlight. So coming to the primary endpoint, as I said, the cycle 1 observed uh, concentration trough. So they have assessed with something called as GMR. This is the geometric mean ratio. So the meaning of this 1.05 is nothing but, see, the meaning was the average trough concentration with subcutaneous was 5% higher than the intravenous. And whereas in model predicted AUC, the GMR was 0.87. So let us understand this again. So here it means that the AUC with the subcutaneous formulation was 87% of the IV exposure. And in other words, the subcutaneous exposure was 13% lower, but still within the predefined acceptable range for non-inferiority. So the next, this slide speaks about the exposure of Tecentriq subcutaneous, not only in the non-small cell lung cancer, but also in the other approved indications such as small cell lung cancer, melanomas, HCC, etc. So the systemic drug exposure following the subcutaneous Tecentriq was consistent with that from the other approved IV clinical studies and supports the use of subcutaneous formulation even for other approved indications, not just non-small cell lung cancer. So so coming to the secondary endpoints, as I said, we need to look at even OS and overall response rates, right? So as we see, the curves are almost same; they do not separate. So hence proven that both are comparable, and the subcutaneous formulation is non-inferior to IV drug formulation. And also when coming to PFS, again, the curves are almost the same. There is not much difference. Again, subcutaneous formulation is proven to be more efficacious. But here, when we see, the numbers are little deceptive because the subcutaneous formulation is giving an objective response of 11.8%, which is a little higher than IV. But that doesn't mean that the subcutaneous is superior. It just means that it has met the endpoint. That is, it has met the non-inferiority. So coming to the safety profile of both the formulations, as we all know that the infusion site reactions are more common with IV formulation, and there were no infusion related reactions in the subcutaneous formulation. And the injection site reactions were less than 5% in subcutaneous form. So, and there were no new or other unexpected safety profiles that were identified. So, both are safe. So, coming to the median administration time, which was 7.1 minutes. So, we can administer immunotherapy not in half an hour, not in 30 minutes or 40 minutes or even 1 hour. No, we can administer this drug in 7 minutes. And although the median time was from 4 to 8 minutes, so it saves a lot of time. So coming that's about 001 trial. Now coming to the 002 trial. The 002 trial mainly tells us that the patient's preference or the quality of life questionnaire, whether the patient was comfortable using subcutaneous formulation or IV formulation. So here, approximately 8 out of 10 patients chose subcutaneous formulation than IV. So that is about 79% in the trial. 79% of the patients chose to complete the treatment with subcutaneous rather than IV. So over here, the 002 trial was a phase 2 open label crossover study of subcutaneous versus IV in PD-L1 positive non-small cell lung cancer. So the eligible patients were almost same, PD-L1 positive patients, non-small cell lung cancer in adjuvant setting, or stage 4 non-small cell lung cancer, but high expression of PD-L1 where monotherapy is approved. So in the ratio of 1:1, so they had given these patients 3 cycles of subcutaneous, like after subcutaneous they switched to IV, and the other set of patients who received first IV then again received subcutaneous. So three cycles each. And after that, according to the patient's choice, they were either given a choice to continue to switch to subcutaneous or to IV formulation. And this patient's choice was assessed by a quality of life questionnaire, that is the CD6DI questionnaire. So the baseline characteristics were matched between both the arms. So now coming to the primary endpoint. So because it is a questionnaire, we want to know the patient's preference. Okay. So the primary endpoint was to know what formulation did the patient prefer. So here, when we see the red color bar is nothing but 70% of the patients preferred subcutaneous formulation. And also when we look at the pie chart, patient satisfaction with Tecentriq subcutaneous, almost 85% were satisfied or very satisfied with the subcutaneous formulation. So the trial outcomes, as I again mentioned, so 80% were happy with the subcutaneous and wanted to continue only subcutaneous formulation. So in the trial also, they had the patients, 64% of the patients said that it requires less clinic time, and it feels 46% of the patients reported that it is more comfortable, and 30% of the patients said that it is less emotionally distressing when receiving subcutaneous formulation. And also 002 trial reported healthcare professional outcomes. So over here also, when we say that not just the patients, even the healthcare professionals also were satisfied, and almost 70 to 80% of the healthcare professionals said that it is the most convenient form of administering immunotherapy or Tecentriq in the form of subcutaneous. Also, there is a question always it arises: can we switch IV to subcutaneous or subcutaneous to IV in rare cases? So the overall safety profile was consistent with established atezolizumab safety profile. No new concerns were identified. Switching between both from subcutaneous to IV or from IV to subcutaneous was well tolerated and did not show any increased toxicity. Yeah, so the increase in the injection site reactions or infusion reaction did not increase when switching to subcutaneous to IV or vice versa. So when we think about immunotherapy, immunotherapy which is given as monotherapy, then you always think about Tecentriq subcutaneous. So where are the indications that the subcutaneous or the atezolizumab Tecentriq is approved as monotherapy? This is according to IM Power 110 in metastatic non-small cell lung cancer patients with PD-L1 expression more than 50%. We have the monotherapy approved. And again, in metastatic non-small cell lung cancer who have progressed on prior chemotherapy in second or third line, according to OAK trial, again, atezolizumab monotherapy is indicated. And the third important one is the adjuvant, in the adjuvant setting, where at least a PD-L1 expression of more than 1% in non-small cell lung cancer patients, we can administer the monotherapy post adjuvant chemotherapy in these patients. So briefly, let me take you through the three important trials. So first line metastatic non-small cell lung cancer, that is the IM Power 10110. Here we want a PD-L1 high expression, that is at least more than 50%. In such patients, yes, we can give Tecentriq as a monotherapy in such patients. And in OAK trial, that is previously treated non-small cell with platinum-based or pemetrexed-based chemotherapy. In second and third line patients, we can give atezolizumab. But here the important point is PD-L1 unselected population. Because the benefit was even clearly visible in PD-L1 negative patients as well. And coming to IM Power 010, here in adjuvant setting, also in PD-L1 expression more than 1%, atezolizumab monotherapy is approved. So Tecentriq delivers survival benefit across all the non-small cell lung cancer journey, from curative intent, that is in adjuvant setting, to metastatic setting. So yeah. So main thing I would like to highlight in PD-L1 high expression, that is more than 50% in metastatic non-small cell lung cancer, the median OS was around 20.2 months versus 13.1 months. So almost there is a 40% reduction in the risk of death versus platinum-based chemotherapy in this subset of patients. And also in OAK, there is if you look at the 4-year OS, here it is 16% versus 9% in these patients. So there's 22% risk of reduction in the death in these patients who received atezolizumab versus docetaxel in these patients in second or third line. And also in adjuvant setting, when adjuvant setting post chemotherapy patients who are being given natizolizumab for at least 1 year versus best supportive care. Over here, the OS was not reached. The median OS is not reached, and the 5 year OS was exceptionally high, that is 74.8% versus 63.3%. So coming to flexibility and economic aspects. So as we all know, it is easy to administer drug, does not require any dilution, and it is the time taken to administer is just 7 minutes. So it definitely reduces the burden in the hospital units in a high volume center, etc. And as we all know that the Tecentriq subcutaneous formulation comes in 1875 milligram vial, single use vial, given every 3 weekly, and given in 7 minutes for the
Excuse
first and
me,
second.
ma'am.
Yes.
Sorry to interrupt, but I just request you to please conclude your presentation as we are over the time here.
Okay. Yeah, I just almost done with my presentations. Let me take you through the summary. Yeah, so Tecentriq subcutaneous is the first PDL1 checkpoint inhibitor which was approved worldwide and now also available in India. And comparable efficacy and safety profile was met between IV and subcutaneous formulation. We went through extensively 001 and 002 trials, and I've also told that 7 minute um, time of administration, and even healthcare professionals and even patients are really happy with this drug. And um, yeah, so that's, I think, about it. So thank you, Rosh, for giving me this opportunity, and thank you for because it is a rare this thing. So I really like the topic. So thank you so much.
Thank you so much, Dr. Nishri, for your insightful session. Now, I'd like to invite our very last speaker, Dr. Srinivas Reddy, Senior Consultant Hepatology at Stars Hospital. Over to you, sir.
Just sharing the slides. Can you share the slides of mine? It's not coming here.
Sure, sir.
Yeah. Can you make full screen? Yeah. Thank you, Rosh, for giving this excellent opportunity for me to present this atezolizumab plus bevacizumab in setting of intermediate HCC. So next slide. So in view of running of time, we'll go quickly about these things. Next. Next slide. So as we see the HCC is the most common in the liver cancers at present primarily. So there is a lot of treatment has developed around HCC. If you see according to the BCLC staging, there is a lot of work is happening in the stage of intermediate HCC, where we can see the local regional therapy, TACE, TARE, and systemic chemotherapy, immunotherapy like atezolizumab and bevacizumab. So in IBRO 150 study, which was showed that combination of anti-PD-1 antibody atezolizumab and anti-VEGF antibody bevacizumab extended survival when compared to sorafenib. Almost survival rate is 16.3 months versus 7.3 months in these studies. Next. So the local regional therapy is a standard of care in intermediate HCC in BCLC-B according to the size of the tumor and according to the involvement of portal vein in these patients. Next. So the dilemma of TACE alone in intermediate advanced HCC. So response rate is reduced after repeated TACEs alone, high tumor burden HCC, and there is a room for improvement in the efficacy of TACE alone. Next. So if you see, this is the slide, the radiological tumor response, complete or partial response rates reduced with each TACE treatment, but the progressive disease rate also increased. If you see the response rate from first stage to fourth stage, almost has reduced of 25%. And the disease progression, if you see, there is an increasing in disease burden only if you do TACE in these patients. Next. So even if you see the graph, the patient with moderate or high tumor burden seems to have poor response to TACE alone in local regional therapy. If you see A graph or B graph, the tumor is high size is more than 5 centimeters or more than number of tumors are more than 5 centimeters. The response rate is very less in these patients. Next. So even this is a metro ticket study. Even if you see the number of tumors are increasing, tumor burden and the progress is also going down in these patients. Next. So this is a large scale real world evidence demonstrates the clinical benefit of combination of TACE with TKI or bevacizumab plus atalizumab. A lot of studies are coming for the combination of these therapies. Next. So this is a beautiful slide, that mechanism, the TACE with combined targeted immunotherapy synergistically modulates the tumor immune microenvironment in these patients and to increase the immunotherapeutic efficacy. If you see here, the TACE alone can cause tumor cell apoptosis, tumor cell necrosis, and death. But along with the TACE plus checkpoint inhibitors, it will activate these tumor cells, T cells, and enhances this efficacy of TACE along with immunotherapy in these patients. Next. So this is the one of the talents slide. This was lastly even we presented even in Vijayawada. Combination of atalizumab plus bevacizumab versus TACE plus atalizumab plus bevacizumab in intermediate stage HCC. Next. So this is the phase 3 open label study. One arm contains TACE plus atalizumab plus bevacizumab. One arm is only TACE in these patients. The confirmed diagnosis of HCC and most likely BCLC-B and BCLC and BCLC for VP1, VP, up to VP2 they have included. Next. If you see the baseline characteristics are almost comparable in all these patients. Next. Next. So if you see here, the combination of local regional therapy plus immunotherapy showed overall response of 11.3 months versus TACE alone 7 months. So this is will indicate that local regional therapy plus systemic therapy showed very good response and increases the progressive free survival in these patients. Next. So as we discussed previously, same the progressive free survival according to the RECIST criteria, 10.3 months versus 6 months in these patients. Next. So almost all some comparatively no major events in these patients when compared to both sides. Next. The primary endpoint, if you see the overall survival, still not mature. It's more of equal. So still the study is ongoing. The overall survival is almost there is no difference. But the progressive free survival is very good in patients with local regional therapy plus systemic therapy. Next. So overall response rate, as we see here, 81% in patients with TACE plus atezolizumab versus TACE alone. And if you see the best overall response according to the RESIST criteria, 50% versus 33% in these patients. Next. The adverse effects, as we know, usually TACE related side effects is post embolization like increased AST ALT levels because of ischemia, these things seen. Next, sir. Next. So, as we discussed, this is a more population. The talent's key take homes is high tumor burden, on demand days. The treatment goal showed overall response rate is almost 49% versus 33%. Next. Can initiation of systemic therapy early in treatment paradigm supports better outcome? Yeah, yes, let's see. Next. So this is the ABC HCC trial where we combine, sorry, not combine, adalimumab plus bevacizumab versus TACE, how it will be affected in these patients. Let's see. Next. So it's till now it is not known that if adalimumab plus bevacizumab is more efficacious than TACE in patients with intermediate stage. By several trials assess the benefit of adding systemic therapy to TACE versus TACE alone, but this ABC-HCC trial directly compares the efficacy and safety of systemic therapy versus TACE. Next. So this is the randomized multicenter trial. In arm A, they have given adalimumab plus bevacizumab. In arm B, TACE accordingly requirement of the patients. Next. So the main inclusion criteria is intermediate HCC, not amenable for surgery or liver transplantation, no extrahepatic disease, and child A up to B7. Next. So the first condition, failure of strategy in arm A and arm B, radiological progression of stable disease. Next. Next. So almost they have included almost patients from this most from the Japan, Italy, and Spain. Next, this study is only till now it is interim analysis study. The date of cutoff we have taken up to 2025. The study is still going on. Next, so the overall comparatively in arm B, or whichever is comparable mostly. Next. If you see here, when compared to adalimumab plus bevacizumab, the median overall survival is 14.59 months when compared with 9.4 months in TACE. Next. So if you see here, the adalimumab bevacizumab number of cycles are 12 and number of TACE cycles were 2. Next. So the result of first interim analysis showed this superiority of systemic therapy when compared to TACE in these patients, but need to see overall results. Next. So the versatile paradigm is adalimumab process is the backbone of intermediate HCC, even for downstaging and even for liver transplant also in these patients. We have a couple of cases, two cases, where advanced HCC, even with VP2, VP4 thrombus, we have given adalimumab bevacizumab almost 6 to 8 cycles. Now patient is underwent transplant 2 years back. Now patient is doing very well. Next. Thank you. Thank you so much for your kind attention. And thank you, Roche, for giving this opportunity. And thank you all for kind attention.
Thank you so much, Dr. Srinivas Reddy. With this, we come to end of the today's scientific session. Thank you so much to all the participants for joining us in making today's session a success on the topic of management of malignant tumors in lung and liver cancers. Thank you once again, everybody. Have a wonderful evening. Stay safe. Good night.
Thank you.
Yeah, thank you.
Tech team, please close the session. And thank you
Sir,
so
can
much.
we end the session?
Sure. Thank you.
Okay, sir. Thank you. Okay, sir. You can leave the meeting.